Welcome back to the deep dive. Today we're really getting into the nitty-gritty of, well, a very common injury, the broken collarbone.
That's right, the clavicle fracture.
Specifically, we're looking at those tricky displaced ones in adults. The midshaft and the distal end fractures, they might seem straightforward, but they're really not, are they?
Far from it. They make up, what, between 2.6% and 4% of all adult fractures? And the vast majority, maybe 80%, are right there in the middle, the midshaft.
And typically affecting that younger active group, people working, playing sports.
Exactly. The working population.
Yeah.
And for us, as orthopedic surgeons, managing these has really shifted over the years. It used to be almost default conservative care.
Right.
But now, well, it's a much more nuanced decision. We're constantly balancing the evidence, looking at function, the financial side of things, and importantly, the risks involved with surgery.
And that's precisely our mission for this deep dive. We want to go beyond just operate or don't operate. We're digging into the modern evidence comparing things like plates versus nails. Looking at the real cost, both for the health system and for the patient themselves. We'll also dissect why certain implants, like the hook plate, have fallen out of favor.
Definitely need to cover that.
And, crucially, how to avoid those rare but potentially devastating complications around nerves and blood vessels.
Yes, mitigating those catastrophic risks is paramount. So, where should we start? Probably with the most common type.
Let's do that. Midshaft clavicle fractures, MSCFs. This is where that tension between cost and function really plays out, isn't it?
Absolutely. And understanding the history here is, I think, quite important. It explains why practice was a certain way for so long.
You mean the move away from just automatically treating them non-operatively?
Exactly. For decades, that was the standard, largely based on some landmark data from back in the 1960s.
Ah, yes, the study suggesting really low non-union rates, around 1% or something. Sounds great on paper.
It does sound reassuring, doesn't it? But, and this is a big but, when you look back at those older studies through a modern lens, well, they had some significant limitations. Well, for one, they often included younger patients, adolescents even, whose bones just heal incredibly well anyway. But more importantly, their definition of success was purely based on the X-ray. Did the bone look healed?
Ah, so they weren't really asking about the patient's actual function.
Precisely. They weren't using patient-reported outcome measures, PROMs, like we do today. Things like the -8 score or constant score. They weren't asking, how quickly did you get back to work? Or how much does your shoulder still bother you?
So a healed X-ray didn't necessarily mean a happy, functional patient.
Not always, no.
Yeah.
So when more modern studies started using these PROMs, the picture began to change quite significantly.
And what did that newer evidence show? What's the general consensus now?
The consensus now, based on quite robust evidence, is that operating during fixation generally gives you significantly lower rates of non-union.
Right. The bone is more likely to heal properly.
Yes, and also fewer problems with symptomatic malunion, where it heals in a bad position causing issues. And, perhaps more visibly for the patient, surgery typically offers a markedly faster return to normal life.
Faster return to daily activities, sport, work.
Exactly. We're often talking weeks, maybe even months. Faster in achieving that maximal function compared to waiting for it to heal on its own.
That faster recovery is definitely a major selling point for surgery. But I remember reading something crucial that often complicates the conversation with patients. What about the final outcome? If the fracture does eventually heal with non-operative treatment, how does the function compare long-term?
This is probably the most critical piece of information we need to convey. And it's perhaps slightly counterintuitive. Multiple good quality meta-analyses have looked at this, and they conclude that the final functional outcome, looking at things like DSH or constant scores at, say, 6 months or a year down the line, is often statistically the same.
The same between those treated surgically and those treated non-operatively if the non-operative ones actually unite.
Correct. Provided the fracture successfully unites without surgery, the long-term function by about 6 months to a year often catches up to those who had the operation.
That does seem odd. If surgery gives you faster healing and less chance of it healing badly, why wouldn't there be a persistent functional benefit?
Well, it likely speaks to the body's amazing ability to adapt, functional adaptation. The shoulder girdle, the clavicle, scapula humerus, rib cage. It's a very mobile system.
Oh, okay.
So if a non-operatively treated fracture does heal, even if it's a bit shortened or slightly rotated, which can happen.
Which is quite common with conservative care, right?
It is. But the muscles around it, especially the trapezius, the serratus anterior, they learn to compensate. The brain essentially recalibrates for that slightly altered anatomy over time. So while the surgical group might hit their peak function faster, maybe at 3 months,
The non-operative group, if it heals, just takes a bit longer to get there.
they often catch up by 6 or 12 months. So the key distinctions we need to make is between a faster recovery, which surgery usually provides, and a better final outcome. And for many, surgery doesn't necessarily guarantee a better final outcome if conservative treatment is successful.
And that distinction, faster recovery versus similar final outcome, really brings the economic factors into sharp focus, doesn't it?
Absolutely, because the financial implications look very different depending on whose perspective you take.
You mean whether we're looking at it from the viewpoint of the healthcare system, the payer, or from the patient's individual finances?
Precisely. Let's start with the payer, say the NHS or a large insurance company. There's been some really interesting cost analysis work done here.
What did that show?
They modeled the expected costs for treating these displaced midshaft fractures. They factored in everything: the initial treatment costs plus the probability and cost of needing delayed surgery later on if the non-operative approach failed.
Okay, so comparing immediate surgery versus trying non-operative first and operating only if needed.
Exactly. And the numbers were quite striking. The expected cost for immediate operative fixation was calculated at around $14,763.
14,700 pounds, okay? That includes the implant, theater time, hospital stay.
Everything, the whole package. Now compare that to the modeled cost for initial non-operative treatment, again factoring in the possibility of delayed surgery for non-union.
And what did that come out as?
Just $3,112.
3,000. So wait, the expected cost is over 11,000 pounds less per patient for the payer if they choose the wait-and-see non-operative approach initially.
That's right. Approximately 11,650 pounds less. It's a huge difference from the perspective of the institution managing the budget.
That's a massive discrepancy. It must put significant pressure on health systems to favor the non-operative route from a purely financial standpoint.
It absolutely does. And they even did sensitivity analyses to see if this held true under different assumptions.
What did that show? Could the balance tip towards surgery if, say, the non-union rate was much higher?
They found that non-operative management remained the most cost-effective choice for the payer unless the rate of delayed surgery needed after non-operative treatment went incredibly high, like approaching 95%.
95%? That's totally unrealistic.
Completely unrealistic. The real-world rates are maybe 15–20%. And even then, it also required the reoperation rate after a primary surgery to simultaneously fall below 15%.
Yeah.
So the model is very robust. Financially, for the system, conservative care wins out significantly.
Okay, so the message to the health system is clear. Non-operative first saves a lot of money. But what about the patient? You said the perspective changes.
It flips completely. When you analyze the costs incurred by the patient, their personal expenses, lost income, need for help, the picture reverses.
How so?
Because the operative patient, while incurring the upfront surgical cost absorbed by the payer, actually experiences a substantial personal economic benefit.
Really? How does that work?
It mainly comes down to time off work, lost productivity.
Because they get back to work faster.
Dramatically faster. The study showed operative patients missed, on average, about 8.4 days of work.
Okay, just over a week. And the non-operative group?
They missed an average of 35.2 days.
35 days, that's nearly 5 weeks compared to just over 1. That's a huge difference in lost wages, especially for younger working people.
It's enormous. If you think about the average daily wage, that difference alone can easily outweigh other costs like physio or needing help at home.
That fourfold difference in time off is really compelling. Were there other patient costs that differed?
Yes. The non-operative group needed help at home for longer, about 7 days on average, compared to 3 days for the surgical group. And interestingly, their physical therapy costs were actually higher.
Higher physio costs for the non-operative group. That seems counterintuitive.
It does, but it was almost double, around 320 pounds for the non-operative group versus 971 pounds for the operative group.
Why would that be?
It suggests that the recovery path without surgery is longer, perhaps requires more intensive or prolonged rehabilitation input to regain function, especially if there's some residual stiffness or slight malunion to overcome.
So, adding it all up, the massive difference in lost work time, needing more help, higher physio costs. What was the overall financial impact on the patient?
The studies calculated that the operative patients experienced an overall net cost reduction to themselves of approximately $5,091 no-nate compared to the non-operative group.
5,000 pounds better off, personally, by having the surgery.
Essentially, yes. It highlights the cost of time. For someone whose livelihood depends on their physical function, a manual laborer, An athlete that faster, more reliable return to function offered by surgery translates directly into less lost income, less personal disruption.
It really lays bare that fundamental tension in health economics, doesn't it? The cheapest option for the system is often the most costly and disruptive for the individual.
Precisely. And it underscores why we absolutely need that shared decision-making process we'll talk about later. You have to be able to lay out both sides of this financial coin for the patient, especially if they're the main earner in their household.
Okay, so that economic reality, particularly the patient's personal cost, might push certain people, the active worker, those with risk factors for non-union towards surgery. But once that decision is made, Professor, we face the next big question. How do we fix it? Plate or nail? Hashtag tag tag 2.1 plate fixation versus intramedullary nailing.
Yes, the choice of implant. This has been debated for years. Plating has perhaps been the more traditional approach, the workhorse. But intramedullary nailing, particularly with titanium elastic nails or KNS nails, has gained a lot of traction because it's less invasive.
Less scarring? Potentially less disruption to the surrounding tissues?
Theoretically, yes. We have some useful quasi-experimental data comparing these directly anatomical locking plates versus TNS nails, mainly in those common displaced midshaft fractures, the Robinson type 2B1s.
And what does that comparison show in terms of how patients do afterwards? Function, pain, healing speed?
Well, the headline finding is that functionally and radiologically, they seem pretty much equivalent in the short to medium term,
Really? No clear winner.
not in terms of function or pain. The studies found no statistically significant difference in pain scores right after surgery. The VAS scores were about 5.4 in both groups on day 1.
Okay.
And, importantly, functional outcomes measured by DH scores at 6, 12, and 24 weeks were also comparable. Neither group was significantly better off functionally during that recovery period.
So whether you use a plate or a nail, the patient's functional recovery trajectory looks pretty similar for the first 6 months or so. What about the bone healing itself? Does one method lead to faster union?
Again, very similar. The time to radiographic union averaged about 12.9 weeks for the plating group and 12.7 weeks for the nailing group.
Practically identical.
Essentially, yes. It suggests that both methods provide enough stability for the bone to heal biologically at its own rate. The implant type doesn't seem to speed up or slow down the fundamental healing process as long as it holds the pieces steady.
Okay, so if function and healing time are basically the same, we need to look for other differences. Were there any advantages in the immediate postoperative period?
There was one difference, albeit relatively minor, that favored the nailing group statistically:
What was that?
a shorter hospital stay. The patients who had nailing averaged about 7.95 days in hospital, whereas the plating group averaged 9.74 days.
So nearly 2 days shorter stay with the nail, that was statistically significant.
It was, yes. The p-value was 0.048, so just scraping significance, but a measurable difference nonetheless.
Why would that be? Is it just because the incision is smaller with nailing?
It's likely a combination of factors. Nailing is generally less invasive, yes. Less soft tissue stripping might mean slightly less immediate post-op pain, maybe allowing patients to meet discharge criteria a bit sooner.
Makes sense.
Also, the surgical time for nailing can often be quicker than plating. Less time under anesthetic generally means a slightly faster initial recovery in those first 24-48 hours. It's probably a collection of these small advantages adding up. Hashtag tag tag 2.2 complication profiles, 31.5% in both groups.
Right. Function and healing are similar, maybe a slightly shorter stay with nails. That brings us to the really crucial deciding factor: complications. If the outcomes are equal, the choice surely comes down to minimizing risk and potential future problems. Now, the study you mentioned reported a complication rate of 31.5% in both groups.
Yes, that figure stood out, 31.5%.
That sounds incredibly high for what we often think of as a relatively standard elective fixation. Nearly 1 in 3 patients having some kind of issue. Does that reflect typical practice?
That's a fair point, and we need to be careful interpreting that number. It's specific to that comparative study, and their definition of complication likely included a broad range of adverse events.
So not just major things like infection or the bone not healing.
Exactly. It probably included things like temporary stiffness, or hardware becoming prominent or uncomfortable and needing removal later on, issues that were managed rather than outright failures. If you looked purely at the major complications, deep infection, non-union, nerve injury, the rates would be much, much lower, thankfully.
Okay, that puts it in perspective. But it still suggests a significant overall burden of problems associated with fixing clavicles, regardless of the method.
It does. Clavicle surgery isn't without its challenges. So let's break down the types of issues seen in each method in that study. Starting with plates.
What went wrong in the plating group?
The main theme was mechanical issues. 3 patients, which was about 15.8% of that group, had the implant loosen.
The plate or screws came loose.
Yes. And that loosening directly led to restricted shoulder movement in those same patients, probably because they then had to be immobilized for longer to try and salvage the situation.
Did the loosening lead to the bone not healing?
In one case, yes. One patient, about 5.3% of the group, went onto a non-union after the implant loosened.
Why would a modern locking plate loosen? Is it usually a technical issue during surgery?
The authors suspected technical factors were key. They specifically mentioned the likely failure to use interfragmentary compression screws, lag screws, in those cases where possible.
Ah, so just relying on the locking screws alone wasn't enough.
Locking plates provide excellent angular stability. They stop the screws toggling, but they don't inherently compress the fracture fragments together. If you don't achieve good bone-on-bone contact first, either with lag screws through the plate or separate ones, the whole construct is relying only on that plate-screw interface.
And that can fail under load.
It can, especially if there's a gap or if the initial surgery involved maybe too much stripping of the periosteum, which can compromise the blood supply needed for healing. Technique matters enormously with plating.
Beyond loosening and non-union, what about just the plate itself being annoying for the patient?
That's a very common issue. Symptomatic hardware. In that study, 6 patients in the plating group asked to have their plate removed after a year, even though they hadn't had a major complication like loosening.
Why? Just because it was prominent or irritating?
Exactly. Plates, especially superior ones, sit right under the skin. They can be prominent, rub on clothing straps, cause discomfort. It's well known that a second operation just to remove the plate is needed in, well, maybe up to 30% of patients long term. That's a significant reoperation burden.
Okay, so plating, risk of loosening if technique isn't spot on, and a high chance of needing the hardware out later. What about the nailing group? What were their specific problems?
The most common issue with the TNS nails was implant prominence at the entry site.
Where the nail goes into the bone medially.
Yes. 3 patients, again 15.8%, just like the plate loosening rate, had irritation and pain specifically because the end of the nail was prominent under the skin near the sternoclavicular joint.
Is that unavoidable with elastic nails?
To some extent, yes. You have to leave the end slightly proud so you can get it out later, but that often means it's palpable and can be uncomfortable, especially with things like backpack straps. It's a known drawback.
Did the nails have mechanical failures too, like the plates loosening?
They had failures, but slightly different types. 2 implant failures led to non-union in the nailing group, which was about 10.5%.
What caused those failures?
One was a refracture after the patient had another fall, suggesting maybe the healed construct wasn't strong enough for high-energy impact, but the other failure was very informative.
How so?
It involved the nail migrating through a comminuted or multifragmentary part of the fracture.
Ah, so the nail didn't have solid bone to hold on to.
Precisely. Intramedullary nails rely on the tube-like shape of the bone, the cortex, to provide stability against rotation and bending. If you have a fracture with lots of small pieces, like a Robinson 2B2 pattern.
The nail doesn't get a good grip.
Exactly. It can't control the rotation, and it might even push through the gaps between fragments. This case really highlighted that nailing is probably not the best choice for highly comminuted fractures. Plates generally handle those better because you can bridge the comminuted segment.
So the take-home seems to be, plates offer robust fixation, good for comminution, but risk hardware symptoms and loosening if not done well. Nails are less invasive, maybe shorter hospital stay, but risk medial end irritation and aren't ideal for shattered fractures.
That's a very good summary of the trade-offs based on that evidence. And implant removal, of course, was routine for the nailing group once union occurred, whereas for plates, it was only if symptomatic.
Okay, let's shift focus now. We've covered the midshaft, the most common area, but what about those fractures right out at the end, the distal clavicle fractures, particularly the unstable ones, the near type 2? These always seem more challenging.
They absolutely are. Biomechanically, they're a completely different beast. Hashtag tag 3.1 non-operative versus operative for near type 2.
Why is that? What makes them so unstable?
It's all about the ligaments. In a near type 2 fracture, the break happens lateral to the strong corticoclavicular ligaments, the coronoid and trapezoid, which normally hold the clavicle down towards the coracoid process.
So the main anchor point is still attached to the small outer piece, but the large inner piece is now free.
Exactly. The main medial fragment gets pulled upwards and backwards by the big neck muscles, like the sternocleidomastoid. But the CC ligaments are still holding the small distal fragment down. This creates huge shear and distraction forces right across the fracture site.
Which makes healing much less likely.
Much less likely. The non-union risk for displaced near type 2 fractures treated non-operatively is alarmingly high. Figures cited are often between 21% or even up to 33%.
Wow, 1 in 3 potentially not healing. That seems like a very strong argument for operating then.
It is the primary reason most surgeons will recommend surgery for these specific injuries, that high failure rate of conservative care.
So does operating on them guarantee a better functional outcome compared to the few that might heal non-operatively?
This is where it gets interesting again, similar to the Midshaft story. An important randomized controlled trial looked specifically at displaced type 2 fractures. And it found that the functional scores, DAHH and constant scores, were actually not statistically different at the 1-year mark between the group that had surgery and the group treated non-operatively.
So even with that high non-union risk, if you do manage to get union without surgery, your final function might be just as good.
It seems so, yes. Again, it speaks to the shoulder's ability to compensate if union is eventually achieved.
But surely the journey to getting that union non-operatively is much rougher, given the high chance of it not healing?
Oh, absolutely. The path is fraught with problems. In that same RCT, the non-operative group had a non-union rate of 37% at 1 year.
37% didn't heal.
Correct. And critically, of those non-unions, about 14% became symptomatic enough that they ended up needing delayed surgery anyway.
So a significant number failed conservative care and needed an operation later. What about patient satisfaction during the recovery?
That was another major difference. Patients in the non-operative group were much less happy, particularly early on.
Why was that? The deformity.
Mostly, yes. The upward displacement of the medial fragment creates a very visible and palpable step-off deformity at the top of the shoulder. Dissatisfaction with shoulder appearance was reported by 33% in the non-operative group at 6 weeks, compared to only 4% in the surgical group.
That cosmetic aspect can be really important to patients. What about getting back to activities?
Again, a clear advantage for surgery. The operative group got back to full sports and recreational activities much faster, especially in the first 6 months. About 78% were back by 6 months, compared to only 44% in the non-operative group.
So for near type 2, the decision seems clearer. Although final function might be similar if it heals non-operatively, the high risk of non-union, the poor cosmetic outcome early on, and the significantly slower return to activity all strongly favor surgery for most active patients.
That's generally the consensus, yes. You're essentially trading the surgical risks and costs for a much higher chance of reliable union, a better early appearance, and a faster recovery timeline.
Okay, so if we're operating on these distal fractures, the next question is what implant to use. For years, the hook plate was very common, wasn't it?
It was. The hook plate seemed like an intuitive solution. The plate fixes the fracture, and the hook goes under the acromion to physically hold the medial fragment down.
But it seems to have fallen dramatically out of favor. Why the big shift away from it?
The evidence has really mounted against it. There's a strong consensus now that hook plate fixation, HPF, is associated with significantly more major complications and often leads to worse clinical outcomes compared to the more modern alternatives.
What are those alternatives?
Things like using anatomical locking plates specifically designed for the distal clavicle, often combined with some form of corticoclavicular, or CC, stabilization techniques that augment or reconstruct the torn ligaments.
So, addressing the ligament injury as well as the bone.
Exactly. Because the hook plate only addressed the bone position, it didn't fix the underlying ligamentous instability. And the hook itself turned out to be the major source of problems.
What direct evidence compares the hook plate to these newer techniques?
There's a good multi-center study, propensity score matched, by Takahashi and colleagues. They compared hook plates directly against locking plates combined with CC fixation.
And what did they find?
The locking plate group had significantly better shoulder function scores, UCLA scores, at both 3 and 6 months after surgery. They were simply doing better during that key recovery phase.
What about the fixation holding up? Bone healing? Complications?
The differences there were quite stark, too. Bone union was 100% in the locking plate group.
Perfect union and the hook plate group.
Only 93.9%. 3 patients in the hook plate group failed to unite. But perhaps more worrying was implant migration.
The hook plate moved.
Yes. Migration of the plate was seen in 18.4% of the hook plate patients.
Nearly 1 in 5. Compared to
0% in the locking plate group. That migration often forces you to take the hook plate out earlier than planned, sometimes before the fracture is fully solid.
That 18.4% migration rate is pretty damning. Why does the hook plate cause so many problems? What's the mechanism behind the pain and stiffness we often saw?
It's fundamentally about anatomical interference. That hook sits right in the subacromial space, under the acromion.
Where the rotator cuff tendons live?
Exactly. Studies using cadavers and imaging have shown just how invasive it is. The hook penetrates the subacromial bursa in almost 90% of cases,
90%.
and it actually makes contact with the supraspinatus tendon during shoulder movement in about 60% of cases.
So it's physically rubbing on the tendon and bursa with every movement.
Pretty much. This inevitably leads to chronic pain, mechanical impingement, inflammation basically. The plate itself causes a rotator cuff impingement syndrome and bursitis. The only way to resolve it is to take the plate out. Plus, putting it in often requires cutting the posterior AC joint capsule, which can add to instability.
It really is a classic case of solving one problem by creating another. So if the hook plate is increasingly becoming a historical footnote, what's the modern approach for fixing these distal fractures reliably?
The clear direction now is towards more anatomical reconstruction. That means using an anatomical locking plate for the distal fragment itself, combined with techniques that address the corticoclavicular ligament disruption.
The CCA, corticoclavicular augmentation.
Yes, using things like strong suture tape, sometimes with cortical buttons for fixation, or even tendon grafts passed around or through the coracoid process to replicate the function of the torn conoid and trapezoid ligaments. This stops that medial fragment riding high.
And biomechanically, are these combined constructs stronger?
The biomechanical testing suggests they are. They offer superior stiffness compared to hook plates, or even just plating alone. Studies looking at constructs combining cortical buttons like the dog bone technique, perhaps with an allograft ligament reconstruction, suggest these might be the stiffest constructs with the highest load to failure.
Stronger against both the upward pull and any front-to-back movement.
Exactly. They seem to restore stability more anatomically.
Now, you mentioned passing things around the coracoid. I know drilling through the coracoid process itself carries risks. Is avoiding that a big advantage of some newer techniques?
It can be, yes. Avoiding coracoid drilling definitely eliminates the specific risk of fracturing the coracoid during surgery, which has been reported, especially if you use large drill bits or rigid fixation devices through it.
So passing suture tapes around it seems safer in that regard.
It avoids that specific risk. However, it's a trade-off. To pass tapes or grafts around the base of the coracoid, you still have to dissect quite carefully in that area.
Which is close to other important structures.
Very close. You're working right near the brachial plexus and the axillary vessels. So while you avoid the risk of coracoid fracture, you potentially increase the risk of neurovascular injury during that dissection. There's no completely risk-free option here. The surgeon has to choose their technique carefully based on the fracture pattern and their own experience, weighing those different potential hazards.
A really important point. Even the best modern techniques require meticulous execution to avoid serious problems. And that brings us squarely to perhaps the most sobering aspect of clavicle surgery. While it offers clear benefits in many cases, it comes with the potential, albeit rare, for truly catastrophic complications involving nerves and blood vessels.
Absolutely. These are the complications that every surgeon dreads, because they can be life or limb-threatening. Understanding the anatomy in the high-risk scenarios is non-negotiable. Hashtag 4.1 anatomy and risk profile.
Can you just remind us of the critical anatomy, especially around the medial end of the clavicle where things are tightest?
The key structure, the one most immediately at risk during medial clavicle surgery, is the subclavian vein. It runs directly behind, almost plastered to, the posterior cortex of the medial clavicle and the sternoclavicular joint.
Right behind where you might be drilling or placing screws.
Exactly. The subclavian artery and the brachial plexus trunks are usually a little further back and slightly deeper, often protected by the scalenus anterior muscle. There's typically a bit more of a buffer zone, maybe 17 to 26 millimeters.
But that buffer can disappear.
It can, especially if the anatomy is distorted by the injury or previous surgery.
So which specific situations should make a surgeon extra cautious? What are the red flags for increased neurovascular risk?
You have to be particularly vigilant with fractures involving the medial third, simply due to that proximity of the vein. Comminution is another risk factor. Sharp bone spikes can be dangerous.
What about timing of surgery?
Delayed fixation, say operating 2 to 4 weeks after the injury, increases risk because scar tissue starts to form and can bind the neurovascular structures to the bone fragments.
Making dissection much harder and riskier.
Definitely. And obviously, Established non-unions or malunions where the anatomy is significantly altered, and any revision surgery where scar tissue is dense and planes or obliterated. These are all high-risk scenarios.
Let's focus on the blood vessels first. What's the most feared, immediate, on-table vascular catastrophe?
That would have to be lacerating the subclavian vein, usually while drilling a screw hole in the medial clavicle.
Yeah.
And the immediate danger isn't just bleeding, although that can be significant. It's the risk of a massive, potentially fatal venous air embolism.
Air getting sucked into the vein, why does that happen?
Because the subclavian vein is essentially part of the central venous system, which is under negative pressure relative to the atmosphere, especially during inspiration. If you make a hole in the vein, the negative intrathoracic pressure can actively suck air into the circulation.
And what does that air do once it's inside?
It travels very quickly to the right side of the heart. The right ventricle simply can't pump air effectively. It's compressible, unlike blood. This creates what's called an airlock,
Stopping the heart from pumping blood.
leading to acute right heart failure, sudden pulmonary hypertension, and catastrophic cardiovascular collapse. It can happen incredibly quickly.
If a surgeon suspects this is happening during an operation, what's the immediate life-saving response?
Firstly, massive resuscitation efforts and an urgent call for help, potentially cardiothoracic surgeons. But the key is to stop more air getting in and manage the air already there.
Ow.
You need to immediately flood the surgical field with saline to create a fluid seal over the hole. Apply direct pressure or pack the bleeding point. The anesthetist needs to apply positive pressure ventilation. And crucially, get the patient into a steep head-down Trendelenburg position.
Why head down?
The aim is to try and trap the air bubble in the apex of the right ventricle or the right atrium, preventing it from blocking the pulmonary outflow tract or entering the coronary arteries. If there's a central line in place, attempting to aspirate air from the right atrium is vital while the vascular injury itself is addressed. It's a true surgical emergency.
Absolutely terrifying. That's the acute disaster. But you also mention delayed vascular problems, time bombs, you call them.
Yes, these tend to be arterial injuries, usually involving the subclavian artery, and they can present much later. We're talking pseudoaneurysms, false aneurysms, where a hole in the artery leaks blood that forms a contained sac, or arteriovenous fistulae, an abnormal connection between the artery and vein.
How do these happen? Usually a screw.
Almost always. It's typically caused by a screw, especially when placed in the medial clavicle, being too long and perforating the back cortex of the bone, constantly rubbing against or even penetrating the subclavian artery wall over time.
And these can present years later.
Easily. The scary thing is the latency. Presentations have been reported anywhere from 2 years up to 10 years after the initial clavicle surgery.
What kind of symptoms should make someone suspect this?
It can be subtle initially. The patient might develop upper limb claudication pain, aching, or fatigue in the arm during activity due to reduced blood flow, or they might notice a swelling in the neck above the clavicle that pulses if it's a pseudoaneurysm,
A pulsatile mass.
or sometimes a bruit, a whooshing sound that can be heard with a stethoscope, or even felt as a thrill if an AV fistula has formed.
And the worst case scenario.
The worst case is an acute presentation. The pseudoaneurysm might thrombose or throw off clots, leading to sudden critical limb ischemia. The arm becomes cold, pale, pulseless. A true emergency requiring immediate vascular intervention.
So any patient with a history of clavicle plating who presents with these kinds of arm symptoms, even years later, needs urgent investigation.
Absolutely. A 3D CT angiogram is usually the first step to visualize the vessels, and they need an urgent referral to vascular surgery. Hashtag 4.3 brachial plexus injuries.
Okay, so we've covered the vessels. What about nerve injuries? The brachial plexus runs right under the clavicle, too. How do injuries to the plexus typically present after surgery?
A significant brachial plexus injury usually presents immediately post-operatively with severe, unrelenting pain, often described as a burning, shooting, radicular pain down the arm, far worse than typical post-surgical soreness.
And weakness, numbness.
Yes, usually accompanied by profound weakness and sensory loss, often in the distribution of the upper trunk of the plexus, the C5 and C6 nerve roots. So difficulty lifting the arm, deltoid, bending the elbow, biceps, and extending the wrist.
What's the most common way the plexus gets injured during clavicle surgery? Is it usually direct damage from a drill or screw?
While direct injury is possible, especially with misplaced medial screws or deep dissection, the most frequent mechanism, particularly in delayed or revision cases, is actually a traction injury, a stretch injury.
How does that happen?
Remember we talked about scar tissue forming in delayed cases? In a fracture that's been left for a few weeks or a non-union, the brachial plexus can become quite adherent to the underside of the clavicle fragments or the surrounding scar tissue.
Okay.
If the surgeon then tries to reduce the fracture, pulling the fragments back into position to plate them without first very carefully releasing all those adhesions.
They end up stretching the nerve.
Exactly. Significant traction force gets transmitted directly to the plexus, causing neuropraxia or even more severe axonal injury. This is why meticulous superiosteel dissection and release of the inferior soft tissues before applying strong reduction forces is so critical in these complex cases.
So careful release first is key. Are there other ways the plexus can be compromised? What about compression?
Yes, compression can also occur, sometimes developing later. This might be from a malunited fragment that's angled downwards, pressing on the plexus in the costoclavicular space, or sometimes some excessive callous new bone formation that encroaches on the space.
Can that be hard to see on a normal X-ray?
It can be very difficult. We've certainly seen cases where a compressing fragment or callus was only clearly identified on a 3D CT scan reconstruction. If a patient develops progressive plexus symptoms after surgery, you have to consider compression and image accordingly.
And if you find compression?
Then urgent surgical decompression or neurolysis is usually required, often best done in conjunction with a specialist peripheral nerve or brachial plexus surgeon. Hashtag tag 4.4 prevention and planning.
Given how devastating these neurovascular injuries can be, prevention is obviously paramount. What are the absolute key steps surgeons must take, especially when tackling a higher risk case?
It starts with preoperative planning. For any complex case, medial fractures, comminuted fractures, delayed presentations, revisions, getting a preoperative 3D CT scan, ideally with angiography, a CT angiogram, is strongly recommended.
What does that give you?
It's invaluable. It allows you to precisely map the relationship between the subclavian vessels, the plexus, and the bone fragments. You can see exactly where the vein is relative to where you might need to drill. You can identify excessive callus or malunion impinging on the neurovascular corridor. It allows you to anticipate problems.
So detailed imaging up front. Then during the surgery itself, what are the non-negotiable technical rules to minimize risk?
Two main things. First, meticulous surgical technique, specifically maintaining a strict superiosteel dissection plane, especially on the underside and medial aspect of the clavicle.
Staying right on the bone.
Right on the bone. The periosteum provides a protective layer. Staying deep to it helps keep the vital structures out of harm's way and preserves blood supply. Second, and absolutely critical, is accurate screw length measurement and placement.
No guessing lengths.
Never. You must drill carefully, ideally perpendicular to the bone surface or along a pre-planned safe trajectory, and then measure the depth accurately with a depth gauge before inserting the screw. You must avoid posterior cortical perforation, especially medially, at all costs.
So meticulous dissection and meticulous drilling and measuring.
If we consistently adhere to those fundamental principles, the risk of these catastrophic complications, while never zero, remains extremely low.
Okay, we've covered a huge amount. The functional outcomes, the costs, the implant choices, the risks. It paints a complex picture where the best treatment isn't always obvious and often depends heavily on the individual patient. This brings us to thinking about specific groups and the whole concept of shared decision-making. Hashtag TAC 5.1 Pediatric and Adolescent Management.
Let's start with children. How does clavicle fracture management differ in pediatrics?
Well, thankfully, it's much more straightforward in younger children. The evidence here is really clear and overwhelming.
Non-operative is the way to go.
Almost always. Children have phenomenal healing potential. Non-union of a clavicle fracture in a child is incredibly rare. For most children, certainly those under about 13, a simple sling for comfort for a few weeks is usually all that's needed. The bone remodels remarkably well.
So surgery is very seldom indicated in young kids. What about older children, adolescents, say over 10 years old? Does the thinking change slightly?
It can do, yes. There's a bit more nuance there. Studies looking specifically at that older pediatric or adolescent group have found something interesting.
What's that?
While conservative treatment still leads to reliable healing and similar functional outcomes compared to surgery in this age group, but the patient satisfaction scores were often lower in the non-operatively treated group, specifically cosmetic satisfaction and overall global satisfaction. Why? Were they unhappy with the bump or the recovery time?
Likely both. They might have experienced more pain for longer, been frustrated by the immobilization, and perhaps been more self-conscious about any residual deformity or bump compared to younger children.
So even if the bone heals perfectly well non-operatively, the experience for the older adolescent might be better with surgery?
That's the suggestion. So for that specific group, perhaps those over 10 or 12, there might be a discussion about considering surgery, maybe minimally invasive fixation, like intramedullary nailing, not necessarily to improve the final function or guarantee union, as that's likely anyway, but more to improve their satisfaction, minimize deformity, and perhaps shorten the recovery period.
So it becomes more of an elective, preference-driven decision in that older adolescent group.
Exactly. It's not usually about avoiding non-union, but about optimizing the patient's journey and perceived outcome. It requires a careful discussion about the pros and cons, including the small risks of surgery versus the potential for dissatisfaction with non-operative treatment. Hashtag 5.2. Identifying the adult high-risk patient.
Okay, that's helpful for the younger end. Now back to adults. We established earlier that if a fracture unites, the final function might be similar regardless of initial treatment. So the key driver for recommending surgery in adults often becomes identifying those patients who are at the highest risk of not uniting with conservative care. How do we pinpoint those individuals?
Yes, risk stratification is crucial. We need to identify the factors that significantly increase the probability of non-union if we choose the non-operative path. Several large studies have helped us quantify these.
What are the big ones, the major red flags for non-union?
There are a few key factors that consistently show up as independently associated with non-union. Smoking is a major one.
How much does smoking increase the risk?
Significantly, the odds ratio is around 3.76. So smokers are nearly 4 times more likely to develop a non-union compared to non-smokers. It really impairs bone healing.
Okay, smoking is number one. What else?
The fracture pattern itself is critical. Comminution having multiple fragments, a shattered appearance, increases the odds of non-union by about 1.75 times.
Makes sense. Mechanically harder to stabilize and heal.
Also, the degree of displacement. Specifically, a lack of cortical apposition, meaning the main ends of the bone aren't touching at all, is a significant risk factor. And interestingly, female sex also appears to be associated with a slightly higher independent risk of non-union.
Female sex. Any idea why?
The reasons aren't entirely clear, possibly hormonal factors or differences in bone biology, but it consistently comes up in large database studies as a small but statistically significant factor.
So if you have, say, a female patient who smokes, and her X-ray shows a completely displaced comminuted midshaft fracture, her chance of healing without surgery is substantially lower.
Dramatically lower, yes. Her individual probability of non-union might be very high, perhaps over 40 or 50%, based on combining those risk factors.
And in that situation, the argument for primary operative fixation becomes much stronger.
Much stronger. In fact, some argue that if we target surgery primarily towards those patients with a high predicted probability of non-union based on these factors, the number needed to treat to prevent one non-union becomes very favorable. It makes the surgery much more efficient and clinically justified.
Beyond those biological and fracture-specific risks, what about the patient's life demands? We touched on this with the economics.
Yes, those are what we'd call relative, but often very compelling indications for surgery. Think about manual laborers, people in physically demanding jobs, or high-level athletes.
They can't afford the time off or the risk of a suboptimal outcome.
Exactly. They often can't tolerate a 35-day average time off work, nor can they accept the risk, even if small, of developing a non-union or a symptomatic malunion that compromises their function long-term. For these individuals, the priority is almost always a rapid, reliable return to full function and definitive healing.
So for them, the benefits of surgery, faster recovery, guaranteed stability, usually outweigh the surgical risks and the institutional cost savings of non-operative care.
In most cases, yes. Their personal and professional circumstances heavily skew the decision towards operative management. Hashtag 5.3, formalizing the shared decision.
Okay, so we have all these layers. The baseline evidence on outcomes, the conflicting economic perspectives, the hardware choices, the specific risks of surgery, the patient's individual risk factors for non-union, and their personal priorities. It all points towards needing a really structured conversation with the patient. Shared decision-making or SDM?
Absolutely. Has to be a formal SDM process. Gone are the days where the surgeon just says, you need an operation or we'll put you in a sling. The complexity demands a collaborative approach.
What's the surgeon's core responsibility in that conversation? How do you translate all this complex data effectively?
The key responsibility is transparency about the probabilities specific to that patient. We need to move away from vague statements like this might not heal and towards providing estimated probabilities based on their individual risk profile and the fracture characteristics.
Can you give an example? You mentioned assessing patients who present later, maybe a delayed union.
Yes.
Let's say you're seeing a patient 6 or 8 weeks after their injury, and you're reassessing whether it's likely to heal non-operatively. There are clinical predictors we can use.
Such as?
Well, if that patient has, say, 3 specific features, their quick day score, a measure of arm function, is still poor, maybe over 40. There's no convincing callus visible on their latest x-ray, and you can physically feel movement at the fracture site when you examine them.
Okay, poor function, no healing sign on X-ray, and it's still moving.
If those 3 things are present, studies suggest you can tell that patient, quite confidently, that they have approximately a 60% chance of this going on to a non-union if left alone.
60%. That's a powerful number. It really changes the conversation from, let's wait a bit longer, to, we probably need to intervene now. Exactly. It provides objective data to support recommending surgery, often to a patient who might have been initially hoping to avoid it. It makes the decision much clearer. The SDM process is about ensuring all this information, the likely functional outcome with each path, the specific complication rates of different implants like hook plates versus locking plates, the patient's personal non-union risk, the economic factors all laid out clearly.
And then the final decision is made together.
It has to be. Taking into account the patient's values, their tolerance for risk, their desired level of involvement in the decision, and their specific life circumstances. It's not just about the surgeon's preference or the hospital's budget, it's a partnership.
And this structure approach applies just as much when discussing options with that older adolescent group, too, making sure they understand the trade-offs between function, cosmetics, and recovery time.
Precisely. We have to acknowledge that factors like cosmetic appearance and the burden of recovery time are valid patient concerns, even if they aren't strictly orthopedic indications in their traditional sense. That's central to modern patient-centered care. #outro.
Professor, this has been an incredibly thorough and insightful deep dive. You've really unpacked the layers of complexity in managing clavicle fractures, moving far beyond just fix it or don't fix it.
Well, I think the key takeaway, particularly for the common midshaft fractures, is that surprising finding.
Yeah.
The final functional outcome, if the bone unites, is often very similar whether you operate or not.
Right, which really shifts the focus.
It does. It pushes the decision onto other factors. Firstly, the economic profile, that stark contrast between what saves the payer money versus what saves the patient money and time. Secondly, the complication profiles of the different surgical options, understanding the issues with plates versus nails, and the clear problems associated with the hook plate for distal fractures.
And thirdly, identifying those patient-specific risk factors like smoking, comminution that tell you who is most likely to fail non-operative treatment anyway.
Exactly. Those 3 pillars really guide the modern management strategy. The goal has shifted, perhaps, from simply achieving union to achieving union quickly, reliably, and with the minimum burden on the patient, whether that burden is financial loss, prolonged recovery, or needing further surgery down the line to remove hardware.
It seems like despite all we know, the quest continues for that perfect fixation method.
It does. We have much better evidence on the trade-offs now, much better understanding of the risks, like those critical neurovascular structures. But the orthopedic community is always striving for that ideal implant, one that provides robust fixation, is minimally invasive, causes no long-term irritation, and carries negligible risk. That perfect balance remains the goal.
A really compelling summary of where we stand and the ongoing challenges. Essential information, I think, for any orthopedic professional navigating these common but complex injuries.
Agree.
And if you, listening, found this discussion valuable and illuminating, perhaps take a moment to rate and share this deep dive with your colleagues. Professor, thank you so much for sharing your expertise today.
My pleasure. Thank you for having me.
Until next time on The Deep Dive.